Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape. The following presentation is part of a certified educational activity provided by Medscape Education and supported by an educational grant from Novo Nordisk.
This program is presented by Medscape Education Global.
Hello, my name is Tina Vilsbo. I'm a medical doctor and a professor at Steno Diabetes Center in Copenhagen, affiliated to the University of Copenhagen. I'm really looking forward to welcoming you to this program entitled Novel Incretin-Based Dual and Triple Agonist, The Future in Diabetes Care. Today, I'm joined by my good friend, Michael Nauk, who is the head of clinical research diabetes at St. Joseph Hospital, Ruhr University in Bochum, Germany. Welcome, Michael.
Hello, Tina.
Michael and I are going to take you through a really interesting overview of, first of all, the personalized, holistic treatment approach of diabetes, different stages of diabetes. We will try to share our interpretation of how the SGLT2 inhibitors and the GLP-1 receptor agonists have really made a big impact in changing the treatment of diabetes. We will share our thoughts about the current GLP-1 receptor agonist, and we'll finalize the program looking into the future on what to expect. We are now spoiled by really, really interesting trials, the CVOTs, the cardiovascular outcome trials in type 2 diabetes. The DPP-4 inhibitors are safe, but the GLP-1 receptor agonist and the SGLT2 inhibitors did indeed change the life story of type 2 diabetes.
Yeah, so especially the GLP-1 receptor agonists and the SGLT2 inhibitors have consistently shown reductions in MACE, which is a composite endpoint of myocardial infarction, stroke, and cardiovascular mortality. In addition, all-cause mortality, hospitalization for heart failure, and kidney-related outcomes have been improved. So GLP-1 receptor agonists are better for the reduction in stroke. SGLT2 inhibitors are better for the reduction of hospitalization for heart failure and kidney-related outcomes. And insulin therapy, which is a competitor, if you like, has not shown any of these effects.
Yeah. So they have really changed how we treat diabetes today. And today we know that the GLP-1 receptor agonists are really interesting, not only the incretin hormone biology being very important in insulin secretion, but also in respect to how they actually work on the brain specifically. A lot of research is now going on in respect to appetite and satiety, even neuroprotection, and the liver, the mainly indirect effect of the liver. So the GLP-1 and the SGLT2 inhibitors are now significant in the guidelines. Guidelines for the treatment of type 2 diabetes have developed rapidly the recent decade. The guidelines are right now very much focused on comorbidities in patients with diabetes. In general, we talk about a left and a right part of the guidelines. The left part of the guidelines focus on patients with atherosclerotic cardiovascular disease, or indication of cardiovascular disease, heart failure, or chronic kidney disease. And in those individuals fulfilling these criteria, it's mandatory that GLP-1 receptor agonist and or SGLT2 inhibitors are used. And that's, of course, based on all the evidence we have. What's also important are that it's actually beyond glycemic control. So these classes actually go before the treatment of metformin or should be added to an ongoing treatment with metformin, even though that HbA1c is normal. On the right side of the guidelines, then it's individuals who struggle with dysglycemia and or challenges with weight. Here, it's split into two columns, you could say, and also within each class, it's actually differentiated which are the most efficacious compounds. I'm a big fan of these guidelines because they're evidence-based, developed due to the fact that there are a lot of head-to-head trials out there who've actually compared, yes, the classes, but also within-class comparisons. Michael, what do you think about the guidelines?
Well, I think we are still discussing how much weight management should be part of the treatment of type 2 diabetes, but there are also some very simple aspects. So still about a third of our patients with type 2 diabetes are treated with insulin, which doesn't have all these advantages. So that means approximately 35% of the total population would be candidates who would have better glycemic management with GLP-1 receptor agonists instead of insulin. The large proportion with pre-existing heart disease, also approximately 35%, also tells us that many, many patients with type 2 diabetes are candidates for such a treatment.
Yeah, I'm also a big fan of the fact that if you have the first injectable, it was insulin for decades. Now GLP-1 has actually been moved up, unless, of course, you're worried about type 1 diabetes or very, very high glucose levels. But if you look at the guidelines, I really appreciate the fact that they're also very holistic. They're very individualized, not only focusing actually on medication, but defining the cardiovascular risk. And there we have to lower blood pressure, lower lipids. We've done that for a long time. But we also have to consider anti-thrombotic agents. And we have to talk to our patients with diabetes about smoking. We have to talk to them about physical exercise, diet, sleep apnea, and so on. I think that's extraordinary important. So a lot of focus has been taken away from glycemic control. We're still discussing the impact of body weight in the treatment. You could say, why are we talking about dual and triple agonist, Michael? What's your consideration about tirzepatide in the guidelines?
Well, what we really know is that tirzepatide has greater effect sizes both for reducing HbA1c and in particular, for reducing body weight. So an interesting head-to-head study has compared tirzepatide, which was a completely new agent, with the most potent selective GLP-1 receptor agonist, semaglutide. And semaglutide performed very, very well, as expected, bringing HbA1c down to 6.4% after 40 weeks of treatment and reducing body weight by more than 6 kilograms. But tirzepatide was better. There, the HbA1c was below 6% in the end of the study, and body weight was reduced by 12 kilograms. So this raises the question about the mechanism, which I don't want to go into because there are many unclear aspects which we cannot fully explain. But clinically speaking, it's a fact that you can put off more weight with the dual agonist as compared with selective GLP-1 receptor agonist. And 10 kilogram weight loss is highly relevant in metabolic terms. So 10 kilograms is approximately what you need to get an early type 2 diabetes into remission. In epidemiological studies, a weight difference by 10 kilograms makes a large difference in the risk of developing future type 2 diabetes. So this is diving into new possibilities which we didn't have with the previous agents. But there are some open questions right now. So what we have known is that the GLP-1 molecule is very potent for the treatment of type 2 diabetes, and that has led to the GLP-1 receptor agonists. And the main mechanisms of action here in the fasting state are an increase in insulin secretion, a suppression of glucagon secretion, and in the postprandial state, a deceleration of gastric emptying, which doesn't allow glucose to rise as much and as quickly after meals. And what we have seen since approximately 2006, when the first GLP-1 receptor agonist was introduced, which was exenatide to be injected twice a day, their HbA1c reduction was clearly below 1%. Weight reduction was just around 1 kilogram. And over the past 1.5 decades, we have seen the effect sizes rise, so that, for example, injectable semaglutide will give you HbA1c reductions of approximately 1.5%. And the interesting thing is that, considering these differences in effect size of the early compounds and our current best GLP-1 receptor agonist, it's not connected to more side effects. So you don't have more nausea and vomiting with semaglutide than people used to have with exenatide in the early days.
Yeah, and that's really, really interesting. Now we're not just talking about glucose lowering, we're actually potentially talking about levels of glycemic control with remission. Tirzepatide actually bring more than half of the patients with the HbA1c below 5.7 without inducing hypoglycemia. And that's fantastic. It's dramatic. Although we don't know how much extra you get out of moving from below 6.5 to 5.7. If you don't have more side effects, if you don't have hypoglycemia, why shouldn't it be a beneficial thing? But in short, Michael, what do you believe that the GIP component in tirzepatide add?
Well, for glycemic control, most likely there is some interaction with GLP-1 receptor stimulation in further improving insulin secretory capacity. That may take a few weeks or months, because usually in type 2 diabetes, the response to GIP receptor stimulation is very weak and probably not clinically meaningful. But maybe that can be reawakened by the stimulus that GLP-1 receptor agonists impose on beta cells, so that they later on respond again to GIP. Regarding weight loss in animals, GIP, like GLP-1, reduces appetite and energy intake, and then obviously the consequence is reduction in body weight. In humans, the robust findings with GLP-1 administration leading to reduced appetite and energy intake has not been simply reproduced with infusions of GIP. So this is a little bit of an open question, and a lot of research is being done right now.
Now we are talking about triple G, so GLP-1, GIP, and glucagon. What's your interpretation in short about that, Michael?
Well, I think glucagon in the past has been looked at as a hormone producing hyperglycemia. And that was why we tried to inhibit glucagon receptors. But the results have been very much disappointing, because that led to all kinds of consequences, including fatty liver disease and lipid abnormalities. So that has been given up. In recent years, we now even believe glucagon, almost like an incretin hormone, may even add to the stimulation of beta cell function. So it could increase insulin secretion. And certainly the element that it adds to the other compounds is an increase in energy expenditure. So GLP-1, perhaps GIP, they only act on energy intake, which is a very important part of the equation. But glucagon, in addition, can make your body spend more energy. And if you spend more energy, body weight will go down further.
And if you look at all the different mechanisms that these peptides have, it's really interesting. We're bringing adipose tissue, we're bringing even brown adipose tissue. pancreas even more, the liver and the muscles into play. And right now, the recent conferences we've heard about CagriSema, a combination of semaglutide and the long-acting amylin cagrilintide. We also have orforglipron, which is a small molecule, an oral non-peptide GLP-1 receptor agonist, which can be taken independently of food intake, which is in contrast to oral semaglutide. We have survodutide, which is a dual glucagon and GLP-1 receptor agonist focusing on very much weight loss. And we have retatrutide or triple G, a combination of GIP, glucagon, and GLP-1 receptor agonist. Michael, can you take us through the most interesting parts of these peptides?
Yeah, thank you. So amylin is known for reducing appetite and perhaps reducing glucagon. And so cagrilintide added to semaglutide gives you, in particular, more weight loss. In type 2 diabetic patients, it doesn't further improve HbA1c, but for achieving greater weight loss. And it's an example that you can combine two peptides and that will give you greater effect sizes. The small molecule oral GLP-1 receptor agonist orforglipron is a real surprise because even in the 1990s, after studying the interaction of GLP-1 with its receptor, it was concluded this is absolutely impossible because a small molecule will never span the distance between two attack points on the receptor. But now it appears possible because probably the computerized systems to analyze the interaction of ligands with receptors has improved very, very much. And you get approximately the same effect sizes that you see with injectable GLP-1 receptor agonist with this small molecule orforglipron. Of course, the furthest advancement is by combining three receptors that are addressed by a single molecule. So glucagon, GLP-1, GIP, and because they all start with a G, it's called triple G or retatrutide. And the glucagon receptor stimulating component is very important because it adds something that the incretins cannot achieve, and that is increasing energy expenditure. But still, the HbA1c is reduced by 2% with high doses of this agent, which shows stimulating glucagon does not necessarily lead to a deterioration of glycemic control, and weight loss was 14 kilograms after 36 weeks, and you can predict that after a year or so it will be even more than that in patients with type 2 diabetes, where weight loss typically is less than in non-diabetic subjects.
Yeah, it's really interesting. But right now we don't have cardiovascular outcomes on tirzepatide, retatrutide, and the other compounds. Right now we have the SELECT trial in obesity, we have the STEP-HFpEF and so on. But there's still a lot of things to be discussed in the future.
Well, I think if you read the literature about what GIP does in the cardiovascular system, it's kind of a mixed bag of advantageous effects and some question marks where you could construct even downsides that GIP receptor stimulation in the cardiovascular system is not universally good. We have preliminary cardiovascular data on tirzepatide, which indicate rather a reduction in events, and this is dose dependent. A very large cardiovascular outcomes trial is being performed right now that will give us much more information. And for the other developments, it's just way too early to expect solid cardiovascular data. That will all come in due time if the development advances.
So I hope that you agree with Michael and I that we are at a very, very interesting time. We have learned a lot with the studies the recent 10 years. GLP-1 and SGLT2 inhibitors are now widely spread in the guidelines, which are very often updated. They're evidence-based. Now we're challenged about the implementation, but we also have a very bright future to look into, not only on the shoulders of GLP-1, but also dual agonist, GIP, glucagon, GLP-1. A lot of really, really interesting trials are going on right now in phase 1, 2, 3, but also we need more data in respect to how they change the life story of type 2 diabetes with respect to cardiovascular disease. It was a pleasure to have you on board. And Michael, I just love the conversation with you. Thank you very much for attending today.
This program was presented by Medscape Education Global.